I am going to keep my introductions minimal so that we can be sure to hear the most from our speakers. So I'm going to invite people to look in your course book, which has bios for our presenters. I will say that it is my privilege to work side by side with our next expert in our Yale program, at our Adult Day program. I invite Dr. Gabriella Balfe to come up to the podium and join us introducing borderline personality disorder to us, but also letting us hear about challenges of working with psychotic experience that can arise. Thank you, Dr. Balfe.
Thank you very much, Seth. Good morning. Keep this in mind because I'm going to ask you about it later. As a full disclaimer, everybody has to make their own disclaimers. I'm not a big researcher. The people who preceded me, the people who follow me, they are, I'm not. Dr. Axelrod asked me to come here and talk from my experience as a clinician. So please keep your Q&A in this area. I was fortunate enough to have listened to a lot of stories that people came to me with. I prescribed a lot of medications. I had good luck, bad luck with some. And then I listened back to the stories people brought me about those. So this is the position I'm talking from. The first time when I realized that cognitive problems can be an issue was a weird episode years ago. I'm not going to say how many, when I was still an internist. And there was a kind lady who I liked a lot, and she liked me, who came to the office. She was extremely upset, and she made my staff miserable. She praised me. She said that I'm the best doctor she's ever seen, but she's not going to come to this office any longer because she was so upset with stuff. And we talked a lot. We established some things. And at the next visit, I was shocked to see that she didn't remember much of that upset she had about the remarks she made. Honestly, she didn't. So this is the first time when I realized that intuitively it's not worth to talk a lot when people are extremely upset. Yeah, go figure. And then later on in my psychiatry residency, I learned strike the iron when it's cold. And that made sense. Then I became very, very interested, and when Seth proposed this topic, I said, yes. So here is what I learned about it. I'm going to tell you all about what I know about borderline personality, about why is this diagnosis so challenging, why primary care doctors don't put it, why we don't make it in emergency rooms and such, why we don't explain it. What's this problem about the cognitive issues? Some challenges that I encounter when I treat people, and some good news, too. So let's go ahead. Mm-hmm. There are several ways to think about borderline personality. The official way is the DSM. This is our Bible. And next Sunday, is going to be the 5th edition. And just by the way, the criteria for borderline personality won't change from the 4th edition TR. So for some reason, they said there are 5 criteria out of 9. I don't know what happens when you have 4 criteria out of 9, and these 4 seem important, like self-harm or feeling empty or angry or dissociating. Nobody knows. On the other hand, this is what angers me about the research, is that can be arbitrary and can rely upon previous research that could have been flawed. So one of the reporters from Psychiatry News tracked down the person who was part of the first task force that participated in the DSM-first writing and asked about the criteria for depression, which, as you know, there's still 5 out of 9. How did you come up with 5 out of 9? What kind of curves and what kind of ROC curves you used to figure that out? And that person said, well, seemed about right. True story. We'll talk about it later. Dr. Linehan's model made a lot more sense to me. And she's so pragmatic, this lady. So She identifies some areas that have problems, these areas of dysregulation like emotional, cognitive, interpersonal, and she proposes some solutions for that. And then you have, in my school, you have to learn about the psychodynamic model. And actually, it makes sense to think about how people think about themselves, how they perceive reality, and what do they do when they're stressed out, how do they cope with stress. And then finally, Dr. Herman and Dr. van der Kolk talk about borderline personality as a complex post-traumatic stress. So DSM is talking about these 9 criteria, about abandonment, about these stormy relationships, about problems thinking about yourself as a sole person, about being impulsive, suicidal at times, being emotionally unstable, feeling empty sometimes, angry, and also, like my lady, then I realized she must have dissociated. She honestly didn't remember anything from what happened in that visit. Well, these were too many lines to remember. So I'm a very pragmatic person, and I prefer mnemonics, like Dr. Linehan would. And this is what I have for you. I'm suicide, and this is how I can remember the criteria. It has to do with abandonment, mood swings, suicide, unstable relationships, difficulty controlling anger, emptiness. You have them all. So now you remember the 3 words, remember the song. This is for me to help me remember things, and what I realized is that songs have a lot to do with unstable emotions, very intense emotions, and this song particularly, which I love, has all the criteria in DSM, because it's a song about relationships, right? Talks about abandonment, talks about emptiness, about impulsivity and substance abuse, so risky behaviors, some paranoid ideation over there, self-harm rather than feeling numb, right? And sense of identity. Let's move on to Dr. Linehan's model. This is a speaker who's been here before, Kyra van Gelder. She is extremely talented, and she can explain things in a way that I can always understand and remember forever. So I borrowed one of her slides that has to do with explaining what borderline personality is about, and she identifies the 3 first areas of dysregulation that Dr. Linehan indicates: emotions, impulsiveness in relationships, and she adds the self-image and cognition. Now, Dr. Linehan is very pragmatic. She invented this phenomenal method of treating people that works, dialectical behavioral therapy, and suffices to say that we're very good at that. Dr. Axelrod can say a lot more about it. Let's move on to my school's model. And this actually made a lot more sense than DSM to me, because you cannot really label people, describe them, and then put them on shelves, put them in nice shoe boxes and say, you're this, you're blue, you're green, you're size 14, whatever. So rather, people are functioning across a continuum. And I agree, we're all nuts. I am sometimes more than others. And the question is, how severe is the nuttiness, and in what flavor? So here's how these people explain it, and the best way to put it, I really like visuals. I think that 80% of the information we transmit via visuals. So look how I think about it. You have these neurotic, healthy people who are very structured and very organized over here, right? And then you have here the psychotic people who are loose, whose boundaries are very, very, very loose, very fluid. For instance, over here, a neurotic, healthy individual would say, well, Seth is pushing me. Sometimes he sounds like my father who's pushing me, but he's a very good mentor, and I'm going to pick up this challenge, and I'm going to do something about it. Over here, Seth, he is my father. I'm going to just disintegrate. I cannot stand this kind of challenge. And I'm going to, this is a loose boundary, loose sense of self, where I am and where Seth begins. And this is the borderline personality level organization, where you can have parts of you that are very, very organized and very structured, you appear very competent, and parts that are looser. And then come the flavors. So here you have the depressive people. So this is me on a good day. Then you have paranoid people. Here you have the head of the CIA. Who else? Let's see, sociopaths. Here you have some famous CEOs over here, right here. And then you have the obsessive compulsive and so forth. So this actually makes a lot more sense to me that people would have different degrees of functioning. They would not be able to keep their lives together. They would have a lot of struggles with that and suffer a lot. And people who would be able, are luckier and they have it easier. This is how Nancy McWilliams writes about it. And she writes about the sense of identity. This is basically where I stop and Seth begins. This is the defenses that the coping mechanisms that people use, and this is how I see reality. Is Seth really angry with me because he didn't tell me that my slides are fabulous? No, he didn't have time to tell me that my slides are fabulous. In terms of primitive defenses, this is a fascinating area. So I was always impressed what people use in interactions. And for instance, one of the main coping mechanisms that people with borderline personality use is splitting. You've heard about it, right? Now, this is not the splitting that you hear in the team morning report, that, oh, this person splits all the time. It's not about that. It's how people who have borderline personality view the world. So when I have borderline personality, I cannot hold in my head the idea that my mom can have some good parts and bad parts, or like Dr. Balf can be phenomenal and know all these medications, and she can be late. She has some flaws. So the idea is that if you think about kids, they have the same problem. They cannot hold in their head the idea that people can be good and bad. And you see this in fairy tales, actually. In fairy tales, you have the stepmom and the good mom, who's usually dead, anyway. But here you have the stepmom who's all bad, the good mom who's all good, and they cannot coexist. But actually, they're the same person as the mom. But the kids need the splitting to understand. That's why people with borderline cannot perceive, in a moment, people can be either very good or very bad. There's nothing in between. Now, the last model I'm going to talk briefly about is the complex post-traumatic stress model, and depends when trauma, the abuse happened in life. It can be trauma with big T, like horrendous sexual abuse, or it can be small t trauma, like Francine Shapiro would say. It can be just bullying, just being invalidated all the time. So here's after Hurricane Irene in my backyard. This is the trees. You have some branches here and there, they're broken. But these trees are standing, and this happened late in their development. What's this? This is a tree that has an identity, the trauma being bent all the time by this continuous pressure from outside. This has entered into its identity. The previous trees are ordinary trees that are trees in my backyard. This one is the DV tree in Aruba. So this is its identity, is bent forever, because the wind always blows in the same direction, that's why. Another way to think about it is how you grow with trauma and with these cognitions, these ideas that you hold about yourself that were inputted from outside. See how they are growing into you. And if you take them apart very quickly and without preparation, guess what happens, right? Now, how many people are we talking about? They were saying in the clip before 15 million. This is a the answer is depends, basically, depending on what sample you use. This is a very large community sample. This is 35,000 people, and the results of which were published in February. This is in general population, basically 3 out of 100 people will have borderline personality. Native Americans more, Asian less. In a hospital setting, 2 out of 5. So what's the problem? Why bother so much with not diagnosing properly and thinking of it and treating it? Sounds so simple, because it's not, because overlaps with so much. This is the problem that I have with studies too, is because usually they select a population that's relatively clear of overlapping problems. And here you have the depression, you have the bipolar, the substance abuse, like it was mentioned earlier. You have the anxiety disorders, and PTSD is one of them, and you have the psychosis. These are the numbers, and again, I'm not a number person. I can tell you, for instance, impress you and say, oh, look, mood disorder. you're 14 times more likely to have a mood disorder. Or I can impress you and say, look at the antisocial or like schizotypals, how many times more likely to have a comorbid condition with that? But I'm a visual person, so look what I prepared for you. From the same community example, you have a lot of substance abuse. 78.2% of people were found to have substance abuse problems. Do you know why? Just because they want? No, because they're treating a condition, actually. Here's the mood disorder, here's the anxiety. Remember, part of it is post-traumatic stress. Then in other studies, everything depends on the studies you're looking at, you find ADHD. And here comes the overlap with the cognition problems that we have. How much of it is dissociation? How much of is post-traumatic stress where people cannot focus because of the trauma and the anxiety? How much is true attention deficit? Then you have the learning disability, and Dr. Zanarini 3 years ago was talking a lot about the eating disorders right over here. Overlaps a lot with axis 2, so you have, here's your paranoid, your antisocial, your narcissistic. And when you see so much overlap, doesn't my watery example make more sense where you have different degrees of organization and different flavors? I put it on its own because regardless of what we talked earlier, this is the admission diagnosis. Guess what? This is what I have to write when I admit you at the hospital, otherwise the insurance won't pay me any money. The truth is, psychotic disorder per se is just in 1% overlap with the borderline personality, but this gets to be axis 1 because otherwise the hospital doesn't get paid. If you think of it, you can stretch and say, well, this makes sense. Sometimes people don't have good reality testing, their moods are fluctuating, must be schizoaffective, right? Then you can think, well, but why not simply bipolar? And Gunderson and Akisko would say that maybe it's a soft bipolar spectrum disorder with extremely rapid cycling. However, people who have borderline tend to fluctuate in negative. They think negatively about them, and they don't quite have this, oh, I feel good, I'm the best kind of feeling that people with mania do. In emptiness, that flavor of depression prevails, and not feeling guilty and ashamed so much. And the mood lability, this comes from outside. They're extremely reactive. It's like they have third-degree burn on their skin, and everything hurts immensely. And actually, this intensity of hurt is what is a good indicator. This is what Zanarini say about the pain of being borderline. I respect a lot and admire the people who had the courage to explain to me what this pain means and how they feel worthless, abandoned, enraged, and how they feel misunderstood. So as treaters, please keep this in mind. Is this complex PTSD? Well, the neuroimaging could say that, definitely. If you look at volumes and you measure and you dye with certain colors, definitely can look like complex PTSD. So let's talk about this cognitive issue that fascinates me. And again, a slide from Kyra Van Gelder where she puts all the main ones. Here you have your black and white thinking. Here you have your paranoid thinking. Here you have seeing people either all good or all bad. When I read post-traumatic stress books, dissociation books, this is what I came up with. And this is one of the main problems that appears, the cognitive distortions that go all along. So this is the black and white thinking, the denial, this is not happening to me. The projection, oh, Seth is angry at me. It's not that I'm afraid, he's angry. Dissociation, this is what happened to my lady, and can be either contained, primary dissociation with nightmares and flashbacks, or you can have it, this out-of-body experience when you're watching yourself, when something bad happens and you don't want to experience it yourself, or when it's very severe and trauma occurred very, very early, you'll see that people develop alters, the multiple personality disorder. Some people in my school may say, I don't believe in that. I've met it. They do exist because they're multiples. And psychosis. So here's the catch with psychosis. What my understanding of it, and from my discussions with Dr. Hoffman, who's my partner at IOP and who is an expert in psychosis and schizophrenia. Psychosis and borderline personality has to do with the splitting. You cannot admit that these negative thoughts are yours. So they're from outside, and there is something different about their flavor. They're not coming from somewhere in a room. So people with borderline, they won't be tempted to turn around and say, oh, who's in the room with me? No, they usually hear it in their head. And usually it's a familiar voice, people who they know, parents. In psychosis, they can be familiar people, but can be others from around, or strangers that say negative things. And really, they turn around to see as if the voices are coming from outside of the head. The best explanation ever for this cognitive perceptual disturbances, I got it from a person who I'm going to name Stacy. So again, I'm grateful that she took the time to explain to me. We had a coaching call one night, and I poured so much wisdom. I had so many good ideas and what to do, and Seth would have been so proud of me the next day. Then the next day she comes. She hadn't done anything from what we talked about. She didn't remember talking to me on the phone. So what's going on? And then she explained this to me, and I'm forever grateful. So she said, see, for you, reality is like this, and she draws a straight line. For me, reality is like this, and she draws these interrupted lines. So if you catch me in between, I cannot remember. And then all of a sudden, the light bulb went off, you know. So this is really and truly what happens when you're dysregulated. You don't have good touch with previous memories. This is the mood-dependent memory. People cannot possibly access their memories of the other persons about the discussions. And here's my favorite song again. You have these memories, but they're scattered. They're not linked together. And this is true, it's actually in people's heads. This is a famous experiment with faces and the reactions they have on normal controls and borderline people. Do you see the difference? I mean, really, this is real. It's not that people try to manipulate us treaters. This is for real. So I chose these pictures because, again, they're worth 1,000 words, and we can have more understanding for what's going on. These are structures that are involved, and I'm going to ask you to remember just 3. This is amygdala. This is our emotional center. This is what tells us this is important. I remember this, and this is going to trigger a lot of things. This is the prefrontal cortex. This is what is going to tell me how much I'm going to act upon these emotions. This is going to direct my behavior. I'm going to be contained, or I'm going to fall apart. And this is the hippocampus. This is where I store my cognitive map. This is how I make sense of what happened before, and I can choose to behave accordingly. So this is the really very basic. I'm going to be very simple about that. And in Dr. Van der Kolk's book, Traumatic Stress, we have this wonderful slide. This is the best slide, really. I made such an extensive literature for search for this conference, and this is the first slide where actually they show how information flows from one center to another. So let me give you some good news. First, the bad news. The guidelines are old, 12 years old. Still on the APA side, we have guidelines that are from 2001, where they're saying just treat the symptoms, basically. If you have the cognitive problems, you do this and this and this. You have them in your handout. If you have emotional disturbances, you do this and this and this. And if you have angry, so basically the 3 clusters of symptoms, you do this and this and this. Well, 6 years later, the World Federation didn't do much better. They were similar in guidelines with the APA, plus they were discouraging benzos. So this is my big problem with benzos, because this is a chronic condition, and we're creating monsters. And actually, Xanax is one of the main ones because it can have this serious discontrol side effect. In England, people were even more radical. They said, we don't advise you to treat anything. That treatment should not be used specifically for this disorder, for symptoms, or for self-harm. Okay, so what are we supposed to do? So 2010 is the last review. Cochrane is our most respected database of guidelines, and they took 10,000 studies, out of which only these were well conducted, and they came up with these ideas. So this is one of the 3 main slides that I'm going to tell you about. You treat the cognitive perceptual symptoms with 2 antipsychotics were shown to be really, really good. Abilify and Zyprexa. Zyprexa, I have a big caveat about it. We'll come down in a second. Anger and impulsivity, remember Topamax, Abilify, and lamotrigine Haldol. Emotional dysregulation, you have some amitriptyline, again, see your Zyprexa, Abilify. Fish oil, actually this is so benign. I said I'm gonna implement it. For suicide, self-harm, again, you see the fish oil. And for interpersonal problems, again, Abilify, Topamax. There's not enough evidence, but they're so benign. Clonidine for the self-harm, for the anger, for anxiety, and naltrexone for basically, like one of my mentors told me, anything that has to do with the pleasure. You can block it. You can block the endorphins with naltrexone. So remember keywords: Abilify, Topamax, Clonidine, naltrexone, fish oil. This is what actually happens. Not too many psychiatrists are taking on borderline personality disorder. So if I am to remain official and be a blank slate, I would lie to you. Officially, there's only one study that says, Gunderson in 2011, that psychiatrists don't take on borderline patients. And to be very honest, this was something that pained me a lot because I like working with borderlines. I think they're caring, and I think they're extremely talented. And hurt me to learn in my last year of school that when somebody came who was very successful to give us tips how to have a successful practice. Screen out the borderlines. Really? So I decided to be transparent and tell you what's going on. That's why you don't find psychiatrists who would take on. So let's go to the medication piece. What do we choose? And there are some problems with non-adherence, so that's why I don't quite like Lamictal, because it takes forever to titrate, and people may forget or be too upset to take it. There's the overdose potential, and you would say, well, I'm not going to prescribe Elavil then. Well, if it's a good medication, I'm going to treat you as my partner. You're an adult. I'm going to tell you, don't overdose on it. But I'm going to still prescribe it because it's good for you. So I trust you, and have clear targets, especially when you have these cognitive distortions, that all or nothing. People would say forever, I don't feel good. Never worked for me. Nothing ever worked for me. So just be clear, and I learned from my psychology friends to put numbers on it. Nonetheless, people end up on many medications. This is an actual list. This is real. 20-something medications on this one. This is what people end up on. And neuroleptics, they're very dirty medications. They don't go on many receptors, and that's why you're going to have so good effects and bad effects. You're going to find on your handouts how we pick and choose based on side effects and what to expect. This is a list that I put together starting from Dr. Stahl's psychopharmacology and monographs for each medication. And this is a question that everybody asks me, and I could only put it together from dozens of studies and monographs, because I wanted to put first generation and second generation neuroleptics in one slide. So here's my Abilify. Do you see it? Remember? And that's why I don't like Zyprexa. Here it is. 9.2 pounds gained in 3 months, if you're lucky. And this is Latuda, the newer one, which apparently is more efficient than Geodon, which I'm not sure how much it works. Everybody asks me about weight, and you cannot predict who's going to gain or not. It's not dose related. It's very difficult to lose. Whomever had problems with weight gain, you can say that this is very hard to lose. They have problems with heart. And I wonder how many of us we actually do check. I don't check weights. That's another disclaimer. But I do send people for their EKGs, and I ask people to, and for the labs, and I ask people to stick their tongue at me periodically. This is the Ames test. We're doing really lousily with checking things. This is after the guidelines came out. This is how we're doing with treaters. So this is a big cry for doing better our part. And because this is this chasm between the guidelines, we know what we have to do and we don't do it. Because we are part of the equation. We may be burned out too. And then we do this. So let me tell you the good news, and this is going to be the end of the practical things I'm going to say. Metformin works. Metformin is a medication that is initially used for diabetes, but also works for the weight gain. In some studies, you can even prevent 7 kilos from being put on, and Topamax works. A tip about metformin, if started slowly. A lot of people tell me that they cannot tolerate because they're started with 500 twice a day. when actually the whole trick is to start it slowly. 250 once a day for a week, then you start 250 twice a day, you titrate it slowly to avoid diarrhea. If that still happens, you switch on the extended release, and that people tolerate much better. Topamax really works, and the cognitive distortions, cognitive problems that can appear, they're reversible, so it's worth a shot. Other medications we use, well, this is always a problem with the copays. This is my cheat sheet. This is how I pick and choose my antidepressants. Do you want less sexual side effects? I'm going to give you Lexapro. Do you want, let's say, more sedation? I can choose between Cymbalta and Effexor. Everybody is asking me about weight gain, so this is my answer to that. And I can tell you about some tips. For instance, Lamictal. My neurology friends would say 50 twice a day, then 100 twice a day the next week. Okay. Abilify started slow because of the akathisia. What else? For the comorbid ADD, set some goals, not just the overall goal, just to feel better. Use the long-acting formulation in the morning, and then when people get home and they have to take care of their kids, the short-acting. Remember to use some cardiovascular medications. My patients know that I prefer propranolol, stage fright for anxiety, clonidine, guanfacine. But for people who use cocaine, this is a biggie. And the way to remember, don't prescribe propranolol for people, beta blockers for people who use cocaine, because you can cause strokes and heart attacks. So the way to remember, there's no B in cocaine, okay? And ECT is always an issue, and if you have severe comorbid depression, it works. Now, measure everything you do, put it on a slide. Don't interrupt things during holidays. And about sleep, let me tell them about sleep. Hypnotics, this is a big problem. So last year in February, this was this big study that came out. So we should be more careful when we prescribe, because we can cut off people's years of life. So everybody should be on a schedule, should limit their distractions, should eliminate this TV from the bedroom. These are not my kids. My kids will never watch TV in their bedroom. And anyway, what you're going to see, this is what you see. Exercise, spirituality. So please, patients, please ask your doctors about choices. Be informed consumers. You're partners in this. You are my partner. So remember the keywords: Abilify, Topamax, Clonidine, Naltrexone, fish oil. Ask your doctor to send you for labs to check your weight. Dear treater, remember where you're starting from. Meet people where they are. Pay attention to yourself. And family members, 2 words: family connections. These are very good references I'm giving you. And thank you, patients, everybody, for educating me, and my mentors for teaching me that there's always hope.
Thank you, Dr. Ball. I have 2 words: great slides. Okay. We have a couple of quick announcements to add. One is our process for asking questions. Hopefully people heard, I should have announced it earlier, is to write your questions on green index cards, pass them to the aisles. One thing to be aware of is that in addition to questions that can come immediately following the presentation, we will have the entire panel discussion time will also be a time to send in questions, which could be directed to individuals or could be directed to multiple individuals. We will have limited question and answer time on these first couple of presentations to get us back on track time-wise, but we will take a few questions to Dr. Balf. I also want to mention, as this is going, if people would be willing to move in toward the middle in the seating, just because we have had more people come in and would like to allow them to come into the auditorium. So I'd appreciate it if people would be willing to shift around. Okay, first question is, would you say a word about how you think a client with borderline personality disorder would do after bariatric surgery, and particularly with regard to issues of poor self-image or unstable sense of self?
Yes! This is one of my favorite topics, actually. When I used to be an internist, I sent 53 people for bariatric surgery. 52 had it. I'm doing all the preoperative screenings for bariatric surgery in the primary care centers. And works. You can get rid of the diabetes, you can improve your self-image. I don't see it as the last resort. This is after your diabetes has wreaked havoc in your body. This is a great, great option. And again, be good partners in this. Ask your doctor about it. Ask them to be sent, because the risks are so minimal and the benefits just absolutely huge.
I don't have other cards reach me. It's possibly because I didn't make the announcement earlier. I would expect people will have questions about this presentation. And again, if you jot them down, or if they occur to you during the day, the panel discussion would be a place where we could have more questions coming. Right now, we don't. I'm going to say thank you so much, Dr. Balf.